A 37-year-old gentleman presents with vomiting, nausea, diarrhea, mild abdominal pain at the emergency department. His vitals are blood pressure 80/60, pulse 96, RR is normal at 16, SpO2 at 96, afebrile. Lab investigation shows hyponatremia and mild hyperkalemia. Blood glucose levels are at 67 mg per deciliter. Physical examination, hyperpigmentation is observed over the knuckles. Now, what is the differential diagnosis in your understanding? What is the most likely diagnosis? What would be the investigation of choice to confirm the diagnosis? How would you treat this patient? And what advice would you give to the patient at discharge? Bismillahirrahmanirrahim. Assalamu alaikum. I am Dr. Tayyib Hamid, and through this platform, I am trying to make an effort to strengthen the foundation, the basic sciences knowledge, as well as the clinical knowledge. So now, as per the case, you can pause the video and you can try to figure out the likely diagnosis and the differential. Now let's go towards the case. So first of all, it's an emergency presentation, and you should act quickly with sound mind and do not panic. So now, when there is a presentation where the electrolytes along with glucose disturbances and hemodynamically unstable patient with GI symptoms, so there's electrolyte disturbance also. So first of all, you should try to rule out adrenal insufficiency. So the other differential can be acute gastroenteritis, it can be sepsis, it can be acute abdomen. So, but in this scenario, since the patient is afebrile, many other differential is unlikely. And even the hyperglycemic hyperosmolar state or decay is also very unlikely, very unlikely, very rare. Not with HHS, but maybe with decay, but still we can't say because the glucose levels are maybe below the normal range or lower limit of the normal. So the most likely diagnosis is a primary adrenal insufficiency. Why not secondary? Because on physical examination, we have observed hyperpigmentation over the knuckles. So now how to confirm this diagnosis? The tests of choice, the investigation of choice would be ACTH stimulation test. So ACTH is given to the patient, and then blood cortisol levels are assessed at 30 minutes and 60 minutes. So if the cortisol levels are below the normal range, so this is confirmed. And then you can also check ACTH levels later to confirm that this is a case of primary adrenal insufficiency. So now there are different causes of primary adrenal insufficiency. In the developing countries, it's usually TB, and the developed countries, it's usually autoimmune disease. So how would you treat this patient? Of course, since the patient is hemodynamically unstable, the glucose levels are also not optimum, so you should give IV colloid as well as dextrose, and then hydrocortisone bolus injection, 100 mg IV, and maybe the hydrocortisone oral drug would continue throughout the life. And what advice would you give to the patient on discharge, which is very important point. So during the sick days or when there is any sort of illness, the patient should double the dose as advised by the physician. This is very important to counter the stress inside the body during any infection. Thank you for watching the video, and you can also watch other videos on this channel relevant to adrenal insufficiency. And if you find the video helpful, so do subscribe to the channel, share with your friends and fellows. Thank you. Take care, stay blessed.